So a large part of my role is working with adults within hospitals in Bradford, and we see any patient on any ward who's got communication or swallowing problems. So the most common reason for referral are adults with neurological problems. So these could be long-term conditions like motor neuron disease, multiple sclerosis, Parkinson's disease, or more acute acquired diseases like strokes. But we also see patients with any other condition.
Well, I first suffered stroke, and it was in the base of my brain, the cerebellum. It was a brainstem injury. Initially, I was admitted into hospital. I could talk at the time. My voice was very deep, very gravelly. I had no swallow reflex at that time either, although I wasn't aware of that until several days later. Not being able to swallow was difficult to deal with emotionally initially because I was on a stroke ward. The 3 surrounding beds were all gentlemen who were considerably older than me, but were able to eat and to swallow normally. So meal times meant that I'd have to sit there not being able to swallow whilst they tucked into their Angel Delight or porridge or whatever it was they were given. At night it was a problem. I had to have a towel on the pillow because I couldn't swallow. There was a danger of phlegm collecting in my mouth, in my throat, and choking. So I had to sleep on my side and allow the saliva to run out onto the pillow, onto the towel. It didn't take long for me to get used to using a cup or a jar to spit into. In fact, you adapt very quickly to not being able to swallow.
Part of my specialism is an X-ray called video fluoroscopy. And video fluoroscopy is a moving X-ray of someone's swallowing ability. Now we carry this out to determine if someone is safe with their swallowing, so if everything's going the right way into their stomach, or if food and drink are going the wrong way down towards their lungs, which can be potentially devastating and cause chest infections and pneumonias. And what a video fluoroscopy allows us to do is not only determine if someone's safe or not, but what level of diet and fluid that we can give them. Are there any strategies and are there any exercises that we can do to help improve their swallowing?
Initially, the SLT team at the hospital took me up to the radiology suite where I had a video fluoroscopy done. This showed that halfway down my throat, the valve wasn't opening to allow anything down into my stomach.
So the information that we gain from video fluoroscopy we can use within our teams, our multidisciplinary team, and with the patient to decide what's going to be best for them in the future.
The SLT team at the hospital were very good in keeping me up to date with my condition. Although obviously I knew that I couldn't swallow, I couldn't eat, but their x-rays, their tests that they performed were very thorough, and they kept me well informed. I was allowed to see the video, because that was an easy way of them explaining why I couldn't, was for me to see why I couldn't swallow. Initially, post-stroke, I was given all my nutrition intravenously. Obviously, this couldn't continue. I was fitted with an NG tube, nasogastric tube, and it wasn't until I approached discharge that it was suggested that we replace the NG tube with a PEG tube. Initially, I was a little apprehensive as I got used to having this tube up my nose and taped to my cheek. But on reflection, it was probably one of the most positive decisions I made. The procedure itself was explained fully to me beforehand. I had no pain, I had no discomfort afterwards. The only bizarre thing was there was this 90 centimetres worth of tubing projecting from my stomach. Once this had been cut down properly and fitted with the correct attachments so I could be fed via the pump, It was just a case of taping it to my stomach. It wasn't visible under my clothing at all.
So we work within a multidisciplinary team and we try to form a holistic goal and a holistic service so that we're all working towards the same thing. So for example, with feeding, the physiotherapist might be working on getting someone able to sit upright. The occupational therapist will be helping them with aids to be able to feed themselves, and I'll be helping them to maintain their swallowing safety, which is all a move towards getting them back into their home or into a more appropriate environment. So the clients we work with, one of our main aims for some of the clients is rehabilitation, so trying to get back towards as normal a function as possible. And we work with the team on communication and or swallowing to try and improve what function they've got left and help them to adapt to their everyday life. And in some cases we get people back to work and back to a good level of functioning in their daily lives.
Very rapidly I moved from being able to swallow a very small amount of water to a mouthful of water. We then pushed this to orange juice, cold tea, coffee, and I now feed normally 3 meals a day, plus snacks and drinks and so on. The support I've received since discharge from hospital from the SLTs has been excellent. I've had various visits at home from the hospital team, in addition to an outpatient clinic in Bradford, where again I've been supplied with everything I've needed. They've offered me support up until, well, still do. If there's anything I need, any difficulties I find myself in, I can contact them. Since being able to swallow a little water, the recovery, both physically and emotionally, has really come on a great deal. And I think without the support of the SLT team as an outpatient and as a hospital patient, I don't think that would have happened.